So we go to Dr. Rifay, is that? Oh, Dr. Holmes here. So it's your turn. You're reporting about low myopia cases, is that right?
Yes.
So thank you very much to be.
So I want to thank Star for this kind invitation and to bring us to this very, very beautiful city. And I think that all people here need a very good ICL to see the beauty of the city. So I will speak about low myopia and astigmatism. I'm a surgeon in ophthalmosurgeon in Morocco. I do refractive surgery and cataract and refractive and keratoconus management only. And I have no disclosure, no financial interest in this presentation. So we all know the technique of the ICL. It's an additive technique. It's a reversible technique, reversible lens. And it's safe. The central hole, maybe this is the key of the reduce of cataract after the ICL. So my patient selection in refractive surgery. So ICL, I use it in high myopia. So no hyperopia. This is of no high myopia and astigmatism. Hyperopia, I've never done this. In all time, I find very, very shallow angle chamber, so never had a case. I have one case, but didn't do the surgery. So I use it also in low and moderate ametropia when I have contraindications in laser vision correction. In Morocco, we have very thin corneas. Most of 50 or 60% of cases are less than 500. So that's why we'll see we do a lot of PRK. And in keratoconus, I use it also in a lot of cases of keratoconus when I treat the cornea with laser or put a ring, then laser, and when I have high ametropia, I can put an ICL and have a lot of cases. So what are my exclusions? Age less than 21. I used to implant kids, but I stopped because of the low. So I stopped in implanting children. The anterior chamber less than 2.8 is contraindication. Specular microscopy less than 2000. And glaucoma, uveitis, zonal abnormalities. I dilate patients. Sometimes I put the mirrors to see the zonula. And with UBM, I make a turn to see if the zonula is good. One-eyed patient, I do not operate one-eyed patient. I've done it 3 times and I stop it because it's very stressful. Retinal disease, I have retinal surgeons with me, so they give me consultation if I operate or not. Iris plateau, iris cysts, so that's why I emphasize about UBM or tumor. I find a lot of iris cysts in UBM and non-realistic patients. So the demand of the patients, psychological evaluation of the patient is very, very good. We have a psychologic file and we do a psychologic evaluation for every case of refractive surgery. Slit eye lamp, IOP, lens angles, all what you need. And I do cycloplegia in all of cases except of keratoconus. So I rely on old glasses, subjective refraction, and I do torical only if the cylinder is more than 1.5 because of the risk of rotation. Sometimes I have to go to the OT 2 or 3 times to re-rotate, so I avoid less than 1.5 and evaluate near vision because a lot of high myopes are false high myopes and we should examine the near vision. So I do the soft contact lens test to every case. Corneal topography, I use MS39, anterior OCT, UBM in every case. I do it by myself. Retinal OCT, specular microscopy, ocular biometry. So this is the anterior, the MS39 that I use. And look at to this case, we have in the OCT 2.8 and in the shame fluke 2.6. So in shame fluke, in pentacam, sometimes you have some misalignment and your depth of the anterior chamber is not true. So if you have less than 2.8, go to the OCT and maybe you will find more and you will earn more patients. The anterior segment OCT, specular microscopy, and UBM. I do measurement with UBM, and I check the ciliary bodies, I check the zonula, and also the patient's behavior. If I touch the eye, the patient is not tolerating, I go to a general anesthesia. If the patient is good, we go through topical. I do also the site with the classical caliper, and I compare all the measurements with the devices and manually. So I have a chart for every case of ICL. So my orthoptists, they follow this chart to take a decision. We use the OCOS to calculate the ICL, and then when I receive the lenses, I verify each lens by myself, and I validate before going to, because sometimes we can have a mistake. So I do it on topical, but sometimes we have some nervous patients, so we do it in general anesthesia. So the technique is the same. I use we use all the 3.2 blade, temporally, viscoelastic methylcellulose. So I think I don't have anything to learn you about this. This is a small video. My technique. I do only one incision. And I do the incision 3.2, and I move from a side to another. I make it 3.3 to let the cartilage entering inside the anterior chamber. I avoid to inject from outside, because sometimes we can have the upside down, so I prefer to get inside the eye. So the surgery is very fast, take 1 or 2 minutes. So I think nothing to learn you about this. I go. So my follow-up, it's refraction. Sometimes after doing pilocarpine, the day after the patient have false myopia. So if you do the myocol, if the patient have -3 or -2 or -4, don't get afraid. Just put a dilation, and this effect will disappear. And we do the OCT to measure the volt. So we speak a lot about volt. I have a first case, -3.5, -4.5. The patient with very thin cornea. So 450. In Morocco, it's normal. I did a study about our corneas. Our normal range is between more than 470. The European normal is for more than 500. The Moroccan is more than 570. But I cannot do LASIK on this, so I go through PRK or phakic IOI. Normal cornea, but thin. So the examination I do also, for all the patients, the myopic and the photopic pupil. Pupillography for all cases, because sometimes we have very wide pupils, and we can have some halos and glares. Specular microscopy, biometry, so all the examination. The cornea is too thin, so it gets implanted with ICL. The fault is 690, and the patient is very happy. Second case, -4, -3, the same, it's very thin. And there is a keratoconus here. There's a small keratoconus. I prefer to avoid PRK to treat ametropia in keratoconus. I can treat the high order aberrations with laser, but not the ametropia. Donc OCT, all the examinations, and this is we do also the binocular examination, orthoptic test for all patients, to see if there is any phoria. This is the psychological evaluation. and the file, the patient was operated and is happy. Third case, -7. So if you come to Morocco, you will see there is, when you find a cornea with 540, you were astonished. I think the same in Spain. The same, donc all the examinations. This is a small video. So I think I skip the video because we'll learn you nothing. The file operated 10 out of 10. All. So potential complication, increase of intraocular pressure. Sometimes just steroids. Cataract. I had 4 cataracts in 8 years. 4 cataracts. Implant dislocation, rotation. Inflammation. I had cases of inflammation. That's why I'm afraid of bilateral. It's not of endophthalmitis, but inflammation. I cannot put lenses in the same day in the 2 eyes because I had some cases of inflammation. Retinal detachments. Yes, I have 4 or 5 cases in general, but not in only this indication. In this low diopter, it means under -6. I have 1 rotation in 65 eyes, done in 2 years. I compared the techniques. So the ICL is 6.1% of all the procedure. We see the PRK are 800 cases. So we do a lot of PRK. So the proportion of low diopters ICL in the all ICLs is 10%. Distribution gender, female, maybe all. Results. So the age of the age is between 20 and 30. So and the results are very good. After 1 month and 3 months, patients are very happy, and we are also happy. There are a lot of papers in literature that speak about low diopters ICLs. That is safe. So it's a safe technique, and it's a choice when you have a cornea that cannot go under LASIK or PRK or ICL. Sometimes it's a choice of the patients. This is my daughter that tell us that EVO ICL is good, and this is my team, and thank you very much.
Thank you very much for the presentation.